Imagine standing outside a pharmacy, holding a diagnosis that finally makes sense of your pain. For millions, the term chemical imbalance provides validating relief. This pharmaceutical fix promises to mechanically reconfigure the brain's synapses, targeting an internal biological malfunction. It reframes years of intense crying and anxiety as a hardware error, stripping away the moral blame of being weak or lazy. This perspective has fostered a type of biological citizenship. We describe our identities and our deepest sorrows through the language of somatic neurochemistry, interpreting our human sadness as a fluctuation of serotonin levels. However, this biological focus individualizes the problem. It medicalizes systemic human suffering, presenting it as a physical defect while effectively neutralizing any critique of the social environments that trigger the distress. This visualization shows the current baseline of modern normalcy. 1 in 5 U.S. adults is taking a psychiatric drug. The volume is so immense that these chemicals are now routinely detected in municipal water supplies. Here is the mystery. Despite the massive, widespread distribution of the supposed biological cure, the rates of severe depression and anxiety continue to escalate year after year. Real-world effectiveness data, such as the STAR-D trial, illustrates a grim reality. While patients often feel an initial spike of relief, the long-term recovery rate is incredibly low. This chart shows a relapse rate of 80% for those staying on the medication. Millions of people are following every medical instruction. They take their pills, they increase their dosages, and they trust the model, yet they remain trapped in unending anxiety and pain. In the late 1970s, the psychiatric field underwent a pivot toward biological modeling. This move was a calculated attempt to preserve the profession's economic viability. At the time, insurance companies were aggressively pulling funding. They were frustrated by the lack of diagnostic reliability in subjective psychoanalysis, where two doctors could rarely agree on a single patient's condition. The publication of the DSM-3 in 1980 solved this financial crisis by standardizing mental illness. It forced complex human experiences into rigid, checkable symptom boxes that could be easily processed for insurance billing. This shift operationalized the clinical encounter. To secure their professional standing, doctors began focusing entirely on the what, the observable symptoms, while systematically ignoring the why of the patient's life story. The specific theory of chemical imbalance was born from a serendipitous accident. In 1952, a failed tuberculosis drug caused an unexpected side effect. Patients were found dancing joyfully in the hospital corridors. Pharmaceutical marketing departments weaponized this observation. They invented the chemical imbalance metaphor because it provided an easily digestible narrative that sold billions of dollars in pills to a culture looking for quick, individual fixes. This data comes from a definitive 2022 review of decades of research. As the chart shows, there is zero consistent scientific evidence linking depression to serotonin activity in the brain. Earlier attempts using chemical brews to drastically lower serotonin in healthy subjects also failed, having no effect on their mood. Modern analysis suggests the lift some feel from these drugs is largely an amplified placebo effect, the result of a patient's strong belief in a medical cure. The most dominant, aggressively marketed scientific explanation for human sadness in modern history has effectively collapsed. Proponents of the biological model claimed that framing depression as a brain disease would reduce stigma. Sociological research proves the opposite has occurred. This is the result of genetic essentialism. By framing the condition as a permanent biological flaw, the public began to fear sufferers as fundamentally broken. It also destroyed the self-efficacy of patients, making them believe they were victims of a hardwired biological destiny. This timeline shows the elimination of the grief exception in the DSM. Originally, doctors were forbidden from diagnosing clinical depression in those who were mourning. Over decades, that window shrank from 1 year to 2 months, until the window was erased entirely in 2013. This absolute biological tunnel vision silences the sufferer. By treating emotional pain as an irrational spasm of the brain, doctors stopped asking, "What happened to you?" and instead simply medicated the symptoms of trauma. Your psychological pain is agonizingly real. However, characterizing it as a hardware error in a broken machine misses the true source of that pain. A complete understanding requires the biopsychosocial model. It demonstrates that our mental health is a synthesis of our biology, our unique psychological history, and our social environment. This framework forces us to confront root causes like systemic poverty, isolation, and trauma. It acknowledges that social environments leave indelible biological marks on our bodies. When we stop viewing depression as a spontaneous chemical error, we return context to our lives. We can finally understand our distress as a valid response to our world and begin the real work of healing.